Welcome to the Board of Health meeting for Wednesday, February 4th, 2026 at 5 p.m. I would like to read this hybrid participation in person or via Zoom. Pursuant to Chapter 2 of the Acts of 2023, an act relative to extending certain COVID-19 measures adopted during the state of emergency signed into law in March 29th, 2023. This meeting will be conducted by a remote means and in person as long as members of the public can easily access the proceedings in real time and participate remotely. Until further notice, this meeting will no longer be broadcast live, but it may be watched when the show is replayed on YouTube. Members of the public who wish to participate in the meetings may do so in the following manner. In person, at the Rope Walk Room located on the second floor at Plymouth Town Hall. Note that the occupancy of the room may be reduced, is small, so may need to reduce the number of attendees that can be accommodated. And today we're doing a virtual meeting that can be joined by Zoom. And you may also send questions or comments via publichealth@plymouth-ma.gov. They will be entered into the record and, as practicable, time permitting, read and addressed by the Board of Health. So welcome, everyone. I'd like to call us to order and talk about approval of minutes.
Dr. Reed, if I could interrupt a moment, I would love to make the suggestion that we change the order of the agenda so that we could hear from Dr. Brown first, and then we
Yes,
can continue with the rest of our agenda once Dr. Brown has finished her presentation with us.
that would be more than good. That would be great. So without further ado, I would like to introduce Dr. Catherine Brown, who is our state epidemiologist for the Commonwealth of Massachusetts. She is also a doctor of veterinary medicine, and she is going to talk to us today about One Health. Welcome.
Thank you so much, Dr. Reed. It looks like Melody has her hand up. Do we want to take that first? No, it's down. Okay. If you all wouldn't mind, I did put together just a few slides for tonight to sort of help me walk through what I wanted to chat with you all tonight about. If that's all right, I'm going to go ahead and share and start. Okay, so One Health is a pretty complicated topic, and I will also say that I don't think there's really a single agreed upon solid definition, but this is one that I particularly like, which is why I'm using it. So it's really around ensuring a collaborative approach using, expertise from multiple disciplines, working at kind of all levels, local up to global. And the goals, and there are multiple goals, right, is to try to work towards sort of health and wellness for people, animals, and the environment. And, I acknowledge I work in public health, which I think often really focuses on the human health aspect of this. And yet, as a veterinarian and someone who, is a sort of a big fan of our environment and protecting it, right? I really view the way for humans to attain their most optimal health is to ensure that everything that our environment and then everything that lives in that environment with us is also healthy. So that's sort of how I think about One Health. But again, there are different ways that people talk about this. Now, again, because I'm a veterinarian, I'm going to focus a little bit on sort of components of this and not try to handle the whole topic in one evening. So I'll just show you a few pictures that kind of represent the different ways that we interact with animals in our environment in Massachusetts, in the US, and then also some globally. Don't recommend coloring chicks for Easter, but it is, it is something that some folks do. Love the idea of having kids get to interact with, recently hatched ducks or chicks, but certainly there's some infectious disease risk there. And then the upper right-hand picture is, more like a state fair type environment where people get to interact with animals. And again, interacting with animals is good, but this looks like a pretty stressful situation for the animals, in my opinion. Research, we can't, whatever you feel about research, right? We utilize animals, and I show the horseshoe crabs in particular, right? Because this is meaningful to Massachusetts. The horseshoe crab blood is harvested to be able to ensure that we have safe medical products. Then we also, again, also at Cape Cod, kind of a Massachusetts, southeastern Massachusetts thing, right? We have these animal strandings, marine mammals and sea turtles that we respond to. There's ecotourism. And so this is, those are the visualizations of kind of different ways that we interact with animals. And then this is a little bit more of a list, but we've already talked about it. And I think most people think really simply about, food, clothing, and pets, but there are all these other components as well and ways that we interact with animals in our world. And that definitely has benefits as well as occasionally causing problems, right? So here's the problems, right? Which zoonotic diseases, so diseases that can spread between animals, or I should say non-human animals and human animals. They're very common throughout the world. And the current estimates are that more than 60% of known infectious diseases in people can be spread from animals. And that doesn't mean they always are, because some of these also are person to person. But then 75% of new or emerging infectious diseases in people come from animals. So, the need for the One Health approach that I talked about, right? Bringing in sort of the multidisciplinary concept for environmental health experts, veterinary medical experts, and then human health experts. Like all of those things are necessary to help sort of mitigate the zoonotic disease risks. So I think some of these major causes of zoonotic disease emergence or reemergence are pretty well known. So there's a global increase in demand for animal protein. And in many countries, including the US, we have really intensified our agriculture to be able to meet some of those demands. We're trying to, increase opportunities for interaction with wildlife. And certainly some of the developing countries that have, really amazing wildlife populations, they certainly benefit from exploiting those wildlife for ecotourism purposes. Land use changes are really big, and these are very important in Massachusetts, right? The urbanization and the habitat restoration all play a role in our environments. The travel and transportation you can get pretty much anywhere in the world in, very, very short period of time. All of that contributes to emergence of disease, and then climate change, of course. So it's like a schematic of the types of diseases that really benefit from a One Health approach. So this is, the square box is the environment that, we all live in. And then we have to think about the reservoir, where the pathogen exists, right? So we can use Triple E as an example. So Eastern equine encephalitis, the reservoir are birds, right? The competent vectors are mosquitoes, which can spread the virus between the birds and then from birds to people. We have to have the pathogen present, right? So in places where there's no Triple E, right, that doesn't matter if you have birds and the mosquitoes because there's no pathogen. And then you need your susceptible population. And it's only where all of these things overlap where you end up seeing these diseases. Um, on this schematic, it actually looks very small, but we all know that these diseases actually happen with some frequency. So infectious diseases are what everybody thinks about when they think about a One Health approach, right? So I've used Triple E as an example. I think I'll give you a little bit of an update on avian influenza in a minute. And then there's all like the animal associated enteric pathogens, right? If you go to a petting zoo, you could potentially be exposed to Salmonella or Campylobacter or E. coli. But there are plenty of other examples of sort of diseases or conditions that could benefit from this One Health type approach. And so, again, just not to take up the whole evening, I'm just providing a couple of examples. So these are non-infectious diseases with an environmental component. So lead poisoning, certainly, certain cancers, and then harmful algal blooms. Those are all sort of examples of non-infectious diseases that I think also can be best addressed through a One Health approach. So I'm going to go. This is actually an old example, but it's a really good one. So there was an outbreak of Mpox back in 2003 in the United States, but it wasn't Mpox the way we think about it now, where it's being transmitted person to person, right? This was people were importing these giant Gambian rats, pouch rats, as pets, and some of them ended up bringing Mpox virus with them when they were imported into the country for the pet trade. And we saw an outbreak of Mpox in pet owners associated with the introduction of this virus. And so, the eventual response at that point was we're never going to import any of these Gambian giant pouched rats or other, rodents that could potentially spread this disease to humans. Now, that was probably a good choice for a lot of reasons, but it isn't necessarily a very popular one. And I think over time, we are seeing changes that make that type of approach increasingly sort of less palatable to people. So a couple of examples. So there was a large foot and mouth disease outbreak. This is a viral disease of cattle. It's not zoonotic, but it is such an important livestock disease that the approach in the United Kingdom back when this happened was to just kill all the cattle. And the effect was so devastating, and there were such large numbers of herds that were killed that, families who had been farming these heritage livestock breeds for, generations, there were suicides. There were, people who completely lost their livelihood and had to change their complete lifestyle and their job because of that. And they still talk about it to this day as being this huge traumatic event. In Hurricane Katrina, we saw people refuse to evacuate without their pets. Avian influenza, when it occurs in backyard birds, right? So instead of these big poultry flocks, these are, maybe more animals that sort of verge on pets, perhaps, as opposed to, just egg producers or meat producers. We've had to, as a society, really adapt the way we respond to those types of outbreaks. And there are some situations where those birds are not actually killed, euthanized, whereas the approach in commercial flocks is definite euthanasia. But again, we have these sort of changing perceptions of animals and their utility in our life. And so sometimes that sort of draconian approach that's been really common in the past might not really be acceptable anymore. Again, a visual about sort of all the ways that we might have animals in our lives. And so this is actually some data for the US with pet ownership survey. It's several years old, so the numbers are a little bit out of date, but even at that time, 11 million backyard chickens, right? And we know that there's more than that now. And so, this is our kind of evolving world and our evolving relationship with animals. So my approach and what I'm sort of advocating to all of you is that when we're thinking about some of these really complex issues that involve the environment, animal health, and human health, that we really need to bring all the different disciplines to the table. So veterinarians, physicians, and other healthcare providers, folks who work in laboratories, right? Diagnosticians, researchers, environmentalists, and we definitely need society. We need the public as part of those discussions as well to try to navigate sort of the complex landscape of our different values in society and how do we balance kind of everybody's needs. I will say that one of my favorite things about working in public health is that I do get to work with all of these different types of disciplines. It really is one of my favorite things. I learn the most when I'm talking to other people who do things that I just don't know anything about. And it's often a very challenging but rewarding experience. So I'll just go quickly into the avian flu update, and then I will take down the slides and we could have conversation. So hopefully you all remember what it was like, particularly in Plymouth, like a year ago, right? When we were seeing all the wild bird die-offs. Plymouth was particularly hard hit, although certainly not the only place that was affected. And since the beginning of 2004, we've had 71 human cases nationwide of avian flu. Some of those, 41 of those folks were exposed by working with infected dairy cattle. 24 of them were exposed working with poultry farms. The 3 that were other animal exposure are like backyard flocks. And there were actually 3 people where the exposure source for them is unknown. Which is always, a little concerning, but the proportion of those cases remains low. We have not seen recently more human cases, which is very encouraging, at least not of the H5N1. You may be aware that there was an avian flu case in a human in Washington state, I think about 2 or 3 months ago, but it was a different subtype of the virus. National flu surveillance is ongoing, all right, and that is actually how some of the human cases were detected, right? We have a very strong flu surveillance program, including in Massachusetts, and we get regular specimens that come into the state lab. So we're tracking, looking for emergence of avian flu. Just as a kind of a reassurance for folks that these cases in humans, most of them have continued to be relatively mild. They're relatively rare. There have been 2 deaths out of those 71 cases, and these are in individuals that had pre-existing medical conditions, and so they were actually very vulnerable to any type of influenza illness. I think this is the last thing I was going to say. So this is very, this is hot off the presses. You can see February 2nd. But up until this finding in the Netherlands, there were no there was no evidence of avian flu H5N1 having spilled over into dairy cow in any other country other than the US. But obviously, there is this evidence that there must have been spillover at least once in the Netherlands. And, I can't explain to you why the Netherlands didn't see like an outbreak the way we did. But what I think is noteworthy is that this is actually now the fourth time that we know that avian flu has gone from birds to cattle. So it's not like a single event where it happened once and then it's only cattle to cattle. This has happened now 4 different times in 4 different locations, which really indicates to us that it unfortunately could continue to happen. And so we really have to now, when we're thinking about avian flu, we really have to think now also about cattle and how are we monitoring these things. There have only been sort of scattered positive wild birds found in Massachusetts. There was that domestic flock that was affected back in end of December, early January on the islands. Milk from dairy farms is being tested through the National Dairy Program. There's continued to be no findings in New England, and we are not so far this winter seeing evidence of significant large die-offs. So that's pretty good news for us so far. And then the last thing I will share with you is that I love zoonotic disease. It's my favorite, right? And certainly we talk about it a lot and focus a lot on the risk that animals, non-human animals, pose to us. But I always use this as an opportunity to remind people that your greatest risk is actually coming from other people, not from animals. All right. And then, so this is my email address. I will leave that up for just a minute in case anybody wants it. And then I will stop sharing so I can see everybody on the screen. Thank you so much. I don't know if that's what you wanted, Karen, when you asked for One Health, but that was what I wanted to share with you. So I hope it was interesting and helpful.
No, absolutely spot on, Dr. Brown. That's exactly what we were hoping for. So thanks for bringing that.
And I want to say that I was fascinated by your approach, and I'm a pediatrician, which I have always said is an awful lot like being a veterinarian, um, with the mystery of what kids get into, and I have in my career I have been exposed to children who have gotten various skin infections and things like that from animals. So I think it's very important for people doctors to ask what animals are people around and being exposed to it, and especially kids. I mean, they get exposed to everything. So I really appreciate that. I wondered if you could talk a little more about you mentioned about algae and blooms and I was thinking about cyanobacter, which we get a lot of in our various ponds in the summertime. And I am also want you to know to be aware that our select board is actually taking that as one of their initiatives to try and work on this cyanobacter because it certainly affects humans. It also affects animals.
Yep.
And it's a real pain in the neck in the in the summertime. So if you could just talk a little about that.
Yeah, I mean, I will say it is not sort of one of my key areas of expertise, right? But this is definitely kind of an environmental condition that is getting worse due to climate change. I think nitrogen runoff from fertilizer and stuff definitely contributes to it as well. And so it does speak very loudly about the health of our environment, when we see these things when we see these blooms happen. Um, I think prevention is obviously something that, we would like to do. So thinking about the ways to minimize, runoff from fertilized land into our water bodies, not easy in a place like Plymouth where, the water is everywhere and the water table is actually very high, right? So it's hard for us, and the fact that climate change, the temperature increases in temperature are actually an important driving factor as well. What I what I would what I tend to focus on when I'm talking about this is really around we would love to prevent it, think about ways to improve your environment. But what's really important is to be aware of the fact that it can happen, look for the signs that it's happening, and then you want to make sure that you, your kids, and your pets are not sort of swimming in that water, drinking it, having any contact with it. I think that's kind of the foundation of what I would say about HABs.
Great, thank you. Anybody else have any questions from the board?
Yeah, I just want to thank you very much, Dr. Brown, for coming. This has been great. I feel like I'm always more on the environmental health was what I studied. So this kind of the connection between humans in the environment is clear. But the thing that I struggle with the most is how do we get humans to listen to us when we talk about this connection? That's an easy one, right?
You know, I mean, I've been doing public health for 21 years. And before that, I was actually a wildlife veterinarian. So, right. So I have a very soft spot for the environment and the important role that it plays in our health and animal health. And to me, it's also obvious and so clear that everything's connected that I really struggle with the why don't other people just understand that? So I don't have a great answer for you, Amy, right? Except that we need to continue to talk about it, right? And to sort of illustrate, really outline for people how those connections occur. So in my job, I spend a lot of time doing that when it comes to Triple E, right? So thinking about trying to explain to people the habitats that drive Triple E activity, how it matters when we build our human habitation, like right around those same habitats, and then helping them understand how the environment and those habitats interact to create like mosquito populations that can pose risk. So really trying to draw those clear connections for folks when in a moment when it's actually important for them, right? In a moment when Triple E actually matters to them and it's a risk that we have to worry about. I think people these days are bombarded with so much information that they just can't pay attention to everything. And so I look for the opportunities when it's meaningful to them to try to bring in components of this One Health and the connection between us all. I don't know if that helps at all, but it's my approach.
No, it really does. I'm like taking notes while you're saying it because it does come down to when people are paying attention because I'm pretty sure I saw something today that there's a heat exhaust training coming up in March, and
Yeah.
it's like, oh, well, we at the local level, we have to start planning for it, but nobody else is caring about heat, over in the summer that we have
Right.
to pay attention to, but we have to plan locally. And I know like the work that Karen and Margaret did last year to get the word out about the birds and what we needed to do about that was amazing. And that doesn't just come to you. That's a lot of time and planning that they put ahead of time to make sure that the residents knew about what was happening. So I think this is really helpful to hear you say that. So then it reminds me like, all right, I got to start working on it now. And then once it pops up, then you can hit them when when they're
Right.
paying attention.
Exactly. And I will just piggyback off of what you just said, a little bit of a tangent, but just to really appreciate the work that is done at the local level, right? I mean, I like working in Massachusetts because I get to work directly with so many folks at the local level, right? There isn't a county interfering in the middle of it the way there is in other states. But so much of the really good work that gets done in this state is at the local level. And so I appreciate all of you for that. Meg.
Meg,
I quickly just wanted to say thank you, Dr. Brown, for coming, responding immediately to our ask, and giving this wonderful presentation. I think it is the wave of the future for public health, as far as that connection piece goes, just like we talk about like the mind body connection with ourselves, like there's a connection with like humans, environment. So I just really appreciate the conversation and education to our community. Amy, when you made a comment like how do we get people to like realize that there's a connection here, I was going to say when people come into Maven and we have to make those phone calls. I think Devin's on the call too, she's our epi. When they're really not feeling well and experience that for themselves, it sets off the alarms for them and their surrounding supports, almost after the fact, but hopefully they take more of a preventative approach moving forward. Thank you.
thanks.
Yeah, thanks for that, Meg. That's another opportunity, right, to grab somebody when it matters to them, right, to talk about some of that things.
Dr. Potvin.
Yes, I just want to join in and certainly thank Katie for the presentation. I was trained as a geneticist, and I recently heard that there's ongoing research to genetically modify mice so that they can no longer transmit the causative agent of Lyme disease. Do you know anything about that? Could you add any information for us? I mean, it seems like something would take a long time to become effective.
Yeah, so I know just enough to be dangerous, right? So yes, that is kind of one of the things that has been proposed as a way to help, combat Lyme disease. And I actually think there's been a fair amount of progress in sort of developing that technology. I have not seen any sort of research about like how effective it might be in a real world setting. I think it would take a long time. I mean, as we all know, mice breed very, very quickly, right? So, I don't know whether these genetically modified mice might be like survive better and therefore outnumber the non-genetically modified ones. I don't know. And I am just going to express some level of reservation or hesitation, not about GMO, like that's fine. But I do worry that there are plenty of examples in human history where we have done things to modify our environment that have ended up very, very badly. And I'll just use a local example of rabbits being imported onto the vineyard for hunting purposes. And unfortunately, they brought tularemia with them, which is now something that we deal with permanently. And that's like one very small local example, but history is rife with these types of things where we've done something to affect a change in the environment somehow, and the downstream consequences, which are very hard to predict because ecological systems are so complicated, but the downstream effects end up being less than perfect. So I do have some reservations, and all I can say is I hope there would be a lot of laboratory testing done first, and then sort of like a fake real world study, not releasing the mice into the wild to really make sure that we have a good handle on how that would work before it happens. But I would love to see something that worked against reducing tick-borne diseases, that's for sure.
Thank you, Dr. Brown. We do have a major problem with that. I know the islands particularly do have a major problem with the tick-borne diseases.
Yeah.
So whenever you hear something that might help, it causes some attention.
Exactly, 100%. And I think we should be casting a wide net and looking for lots of different solutions, right? Let's be creative, but then let's also be kind of thoughtful about how we deploy them. That's all I advocate for.
Yeah, thank you, Dr. Brown.
Thank you. Any other questions? Well, I just want to thank you again for taking the time. We always enjoy learning about broader things than what we think about. And this one was really good. We may have to have you come back at another time. We'll find another topic you can talk to us about.
Well, I really appreciate the invitation very much. And again,
Yeah.
appreciate all of you at the local level for everything you do for our residents.
Great.
And
Thanks
I'm
so
going to head off and drive home if that's okay.
much.
Okay, good luck.
Thanks, Dr. Brown.
Thank you, Dr.
Thank you.
Brown.
Yeah,
Have a great
bye-bye.
night. And
Okay,
if I could just, again, Dr. Reed, I'm sorry to interrupt, but
that's
we
okay.
do have a person who's just listed his iPhone, and our policy here with the Board of Health is that you have to have a name when you have. So we're going to give you about a couple minutes to change from iPhone to a name, or if not, if we don't see that change, we're going to have to remove you from the chat. So just wanted to let you know. Thank you.
And just a reminder, Lego guy is Kate, right? Okay. I kept looking for
I'm
her.
so
He has
sorry.
her
My
photo.
computer will not come on for some reason. Yes, it's me.
Okay. Thanks. Okay, so we'll go back to approval of the minutes. Minutes from 1/7/26. Do you all have a chance to read them? And any changes or modifications? Okay.
I'll make a
Someone like,
motion to accept them as written.
yes?
I'll second.
Okay, we have a motion by Amy and a second by Meg. All in favor? Dr.
Aye.
Potvin?
Yes.
I have to do it now
I
this
know
way,
I
right?
forgot. Sorry.
Meg,
Yes.
Katie,
Yes.
and Amy,
Yes.
and myself, yes. So they have been approved unanimously. From 1/21/26. Any changes or additions? Okay, can I have a motion to accept?
I'll make the motion to accept the meeting minutes.
Okay, and a second?
I'll second.
Okay, so Amy made a motion and Meg second. All those in favor? Dr. Potvin,
Yes.
Amy,
Yes.
Meg,
Yes.
and Katie,
Yes.
and myself, yes. So they have been approved. Okay. So I was we were going to do public comments now. And I really want everyone to keep their comments to 3 minutes because I see a lot of you there and we'll be here forever if we don't do that. So can someone keep track of the time for me, 3 minutes?
Yeah, I definitely will. And also
Okay.
to the chair, Dr. Reed, if I could,
Yes,
I see a lot of familiar names and faces. I
yes.
would request that if you have new information to share, that would be wonderful for us to hear. But if you're saying something that you've already said or you've already sent an email with that information, I would request that you not repeat it. So if everyone is okay with that, I think we can certainly go ahead. But again, please raise your hand if you have something new to add to anything that's on the agenda. But if you've already sent an email or spoken before and there's nothing new to add, then you can certainly, I encourage you to listen, but perhaps not repeat. Thank you.
Okay. So we'll start with Melody. You're muted, Melody.
There we go.
There you go.
Um, I'm asking you today to follow the current federal trajectory about regulating kratom and 7-OH. Just last week, they reiterated in the Great American Recovery Initiative that they are after 7-OH. They did not mention kratom at all. And so they are keeping in line with the press conference that I participated in with them, where they asked me to talk about the benefits of kratom and how it's been very positive for me and my family. And I just wanted to ask you to follow their current trajectory with kratom and 7-OH. And thanks for your time. I appreciate it.
Yes, thank you. Thank you as well. I can't see the name, all the names.
I can help you with that, Dr. Reed, if you'd like. The next person listed is Susan.
Oh, Susan. That picture looks, is that Susan? Okay.
There is a Susan that has her hand raised, so if she would like
Okay.
to unmute and
Susan?
speak.
Hello,
Yes.
my name is Susan Eppard, and I support banning all forms of kratom. As my 22-year-old son Matthew died from kratom, it was kratom powder. It wasn't 7-OH or any of the new spin-off kratom things that they're coming up with now. It was back in 2021, so it was over 4 years ago before 7-OH hit the market. And the kratom caused him, according to toxicology and autopsy, it caused him to have a seizure and go into cardiac arrest and die right on his kitchen floor while playing cards with his girlfriend. And she is forever distraught by this, and so is all of our family. And it was his autopsy and toxicology showed he died from the tox effects of mitragynine, an alkaloid found only in kratom. He had no prescription drugs, no street drugs, nor alcohol in his system when he died, and he had no underlying health conditions. And also, I spoke with the FDA about my son's death, and they are actively investigating all kratom deaths reported to them. The FDA has not changed their position on kratom, and this is directly from the website of the FDA. It says the FDA has warned consumers not to use kratom because of the risk of serious adverse events, including liver toxicity, seizures, which my son had, and substance use disorder, and in some cases, death. Please ban all forms of kratom and don't put other parents through this nightmare that I have to live with every single day of my life. Thank you.
I'm gonna ask as well, when you speak, anyone who's going to speak, state your name again as Susan did do, but also tell us where you're from. So Susan, can you let us know where you're from, please?
Yes, I'm from Muskegon, Michigan, but a friend of mine, Holly Truville, lost her son and only child, and she lives in Massachusetts, and she can't be here today because she's traveling to Florida.
Okay, thank you.
Thank you.
Thank you, Susan. I'm very sorry for your loss, and thank you for sharing.
Thank you.
The next person to speak will be Jeff Willett.
Yeah, thanks, and good evening. Members of the Board of Health, my name is Jeffrey Willett. I'm currently in Kansas City, Missouri. I have 20 years of senior leadership experience in tobacco control and smoking cessation programs, including having served as a national vice president at the American Heart Association and as director of the New York State Bureau of Tobacco Control. And I currently serve as an advisor on tobacco harm reduction to PMI US Services, Inc. I'm speaking tonight in opposition to the proposed 6 milligram restriction on nicotine pouches. As you know, according to the Massachusetts Office of Health and Human Services, 1 in 10 adults in Massachusetts, roughly 566,000 people, continue to smoke cigarettes. Cigarette smoking specifically, not nicotine use generally, is the leading preventable cause of death in Massachusetts. And most people who smoke cigarettes want to quit. and roughly half attempt to quit each year. And while behavioral counseling and FDA-approved pharmacotherapies can increase success, fewer than 1 in 10 people successfully quit using traditional cessation approaches. In contrast, many people are turning to lower risk alternatives to move away from smoking. For example, recently published studies by Yale and Rutgers universities indicated that adult use of nicotine pouches is associated with reduced cigarette smoking, and that pouch use is most common among adults who recently quit using other tobacco products. The FDA conducts rigorous scientific reviews of new tobacco products, including evaluations of product chemistry and toxicity, whether the products are likely to help adult smokers switch away from cigarettes, and analyses of youth appeal. And through this process, FDA determines several nicotine pouches meet a statutory public health standard and are likely to benefit adults who currently smoke cigarettes by encouraging switching away from them. So quite simply, the proposed limit on nicotine concentration is not grounded in evidence regarding nicotine toxicity or addiction potential. Notably, the FDA recently authorized pouches with concentrations exceeding 6 milligrams, and FDA stated these products, quote, have the potential to provide a benefit to adults who smoke cigarettes and or use other smokeless tobacco products that is sufficient to outweigh the risks of the products, including to youth. But for pouches to serve as effective alternatives to smoking, they must deliver sufficient nicotine to substitute for combustible cigarettes, particularly during initial switching. And for some adults, higher nicotine options are necessary to enable complete switching away from smoking. Adults who find nicotine delivery inadequate are more likely to continue smoking. So for adults who've been unable to quit using nicotine abstinence approaches, pouches represent a demonstrably lower risk alternative to cigarettes. To improve public health, FDA authorized nicotine pouches should remain available to adults wherever cigarettes are sold, and then in the nicotine concentrations FDA has determined meet a public health standard. So in conclusion, I respectfully encourage you to oppose restrictions on nicotine pouches that would undermine efforts to reduce smoking and conflict with strong science-based regulatory decisions. Thank you very much for your time this evening.
Okay.
Thank you very much, Jeff.
Okay, the next person is Dan Griffin. And he's gone. So the next person would be Dan Gibbs. Oh, Dan Griffin, are you there?
Yeah, sorry about that. I was
Okay.
trying to unmute my phone. I'm not too versed in Zoom. I'm just
okay.
wondering, the tobacco regulations that you guys wanted to talk about today, are those just the nicotine pouch, or are we talking about other tobacco regulations as well?
Well, it's mainly about the nicotine pouch because that's what's being changed in the recommendations that we have right now.
Okay. Then I will talk about kratom. So we do run. My name is Dan Griffin. I do live in Plymouth. I do work at smoke shops in Plymouth. We do have some in towns that have banned kratom already, and we do sell fentanyl test kits in our stores. I can tell you as a fact that the fentanyl test kits have been flying off the shelves in towns that have banned kratom. People do use kratom to get off of opioids, and like the people do say, oh, they can just go to rehab, they can, whatever. Some people don't want to ruin their lives. Like some of the people that do use kratom are like your neighbors. You wouldn't suspect it. They got hooked on pills when they were younger, and now they're trying to get off of opioids using kratom. That's just my thought on it. And then for Barry, who mentioned Lyme disease earlier with ticks, I know this is jumping points real quick, but the town could do like state-sponsored, like 4-post feeding stations for deer. That's worked in other states to like mitigate Lyme disease. It would probably work here. So.
Okay, thank you very much, Dan.
And then the next person with their hand raised is Dan Gibbs.
Yes, good evening, board members of the board. My name is Dan Gibbs. I'm an Ohio resident. I was asked by Holly Truville, who is a Massachusetts resident, to speak on her behalf. Earlier, I did submit a clinical and policy record regarding kratom and its associated public health impacts for inclusion in tonight's record. But my goal this evening is not to repeat that submission, but to briefly contextualize why it matters. Kratom is often discussed as a benign or low-risk substance, but the clinical and regulatory record tells a different story. Its primary alkaloids act on opioid receptors. Repeated use can lead to dependence and withdrawal, and states operating under consumer protection models continue to report poison center calls, emergency department visits, and serious adverse outcomes. Importantly, some of the research often cited to reassure policymakers is often being mischaracterized. Short-term tolerability studies in healthy volunteers are not safety determinations, do not establish safe dosing, and were not conducted or approved by the FDA. Describing them that way gives a false sense of certainty where none exist. I would also note that many of the most common user statements presented as evidence of kratom's benefit, such as inability to function without it or reliance for daily activities, are clinically warning signs of dependence rather than reassurance of safety. Taken together, the issue before public health bodies is not whether some individuals perceive benefit, but whether normalization of an opioid active substance with unpredictable potency and documented harm is consistent with public health protection. Thank you for your time and considering the full record already submitted. Thank you.
Thank you, Dan.
And that's it. There's no other hands raised.
Okay. Very good. We'll continue on then with,
Actually, I apologize. There's
yeah, I see
somebody.
someone.
Yes, S. Patel has their hand raised.
Okay.
Hi, my name is Sachin Patel, 233 Sandwich Street. I'm a resident of Plymouth. I just wanted to point out, bring to attention to the committee that all the town board of health meetings from December 3rd are not on the YouTube channel. Thank you.
Okay. Can we look into that,
Yeah,
Margaret or
thank you for
Karen?
bringing that to our attention. But again, we have no control over that. That's by the local scene, which is a local public access television. So it's whenever they get a chance to actually post them. So you can certainly look at the minutes. They're posted on the website, but to actually see the video, it's going to be at the discretion of the local scene.
Okay, thank you. Thank you for the explanation.
You're welcome.
Thank you. Okay, moving on to Board of Health member updates. Meg, do you have any updates on CHA chip, PHE?
Yeah, so CHA chip, that's the community health assessment, community health improvement plan that we are working on with Health and Human Services for the town of Plymouth. We have not had a meeting since the last time I was giving an update. There was an email recently, Karen. Is there something to mention to the group about the CHA chip?
Right. There's gonna be a kickoff meeting. I believe it's March 21st at the Plymouth Public Library. And it's going to be sort of a recap of what's happened so far. I can let you know that they are interviewing 20 what they call key informants. I was one of them and I haven't interviewed. So they are definitely working on that, interviewing the 20 people. Then their plan is to have 10 focus groups with residents, about 6 to 10 in each focus group. But those are being worked on right now. They're not scheduled yet. So they're collecting information from the 20 interviews and then they'll move on to the focus groups. Then on I want to say it's March 21st, that's when they'll present what information they've gathered up until this point. So that's where we're looking at next. Let me just double check before I say anything else about March 21st. It is, nope, because that's a Saturday, so that's not going to be happening. Um, let me continue to look if you want to move on, and I'll pop back in when I find out when it is.
Okay. Anything else, Meg?
And then for the public health excellence coalition. We actually, I don't know if Devin's still on. I think it looks like she may have hopped off. She is leading the charge on coordinating a community baby shower to fulfill one of our foundations of public health buckets. So more to come on that. I think she's pairing it, or we're going to be offering this community baby shower at an existing event at Plymouth North High School, I believe. I could get more details on that. And then also in the process of hiring a food inspector and public health nurse.
Okay, and the Plymouth Char key findings and chip kickoff will be Thursday, March 26th at noon, and that will be at the Plymouth Public Library from 12 to 3.
And
Thanks,
anyone is invited to that?
I believe so.
Okay.
Mhm.
Okay, very good. Dr. Potvin, Nuclear Decommissioned Citizens Advisory Panel.
Yeah, well, this will be quick. The meeting in January was scheduled for Monday, the 26th, I believe. Town hall was closed, so they tried to arrange to do it purely remotely. And the chair was not able to assemble a quorum, so the meeting didn't happen. It won't be rescheduled. The next scheduled meeting is, I believe, for Monday, March 23rd. And at that meeting, what was supposed to happen in January is probably going to happen at that date. So there is really nothing I can report on.
Okay, very good. Thank you. Plymouth Youth Development Collaboration. That I attended that meeting recently, and I have a couple of things to talk about. One is there is a new program here in Plymouth called the Futures Program. And the Futures Program is to work with children with autism and Down syndrome. It's a grant, a granted program that's just started. They have licensed behavioral analysts to develop individual care plans for families that are maybe having some trouble with their children that have autism or Down syndrome to help support them and develop, help them with their development. So this looks like a great new program that they're looking for people to come to quickly because right now they don't have anybody, so you'll get right in. And the number that you can call is 800 244 4691. It's located right here in Plymouth. And you can also visit them on their website, which is SEVITA, sevitahealth.com/futures. So I would recommend anyone that's having any issues with their special needs children to get a hold of them. That's really great. The next thing that they talked about, which I thought was interesting, had to do with a new product that's coming out that high school students are now all onto, and I had never heard it before. It's called Smart Vapes. I don't know if any of you have heard of it. Well, I would recommend you go out, just Google Smart Vapes, go out and see what this is all about. I did that and I was quite surprised. Essentially, it's a vape that is also associated with electronic gaming. And so it gives you, as you vape, it gives you an ability to be able to go and do the gaming. It sort of supports both of those habits. The kids are really getting addicted to not only the vaping now, but also the games, and they've kind of put it both together. So that's a new thing to be aware of. The other thing that they did talk about was they gave a little kratom update at the state level, and there are a number of bills. There are actually 5 bills in the House and 2 in the Senate. I have all of those numbers if you want them, or you can go out and look them up on the website. But I just want you to be aware that there are things going on at the state level about kratom as well. So those are the 2 things from there. And I also attended the Plymouth School Nurses Wellness meeting. And at that meeting, it's interesting, Meg, you talked about a community baby shower. They actually talked to about a community baby shower that's going to be in Middleborough. Are there going to be more than one? Is that okay?
Seems to be the trend.
So this is one that they talked about there. They didn't talk about our Plymouth one, which I thought was interesting, but this is going to be in Middleborough on March 28th from 10 to 2, and it's going to be at the Town Hall Ballroom in Middleborough.
I think Devin is actually assisting them with that on how to get it kicked off and organized.
Oh, good, good. So yeah, that's another thing that's really great. And then let me see, I did have one other thing. Oh, didn't I? Nope, that's all from there. The Citizens Advisory Council. So the last time we talked about this, we talked about the possibility of putting some information in a paper or something. Did we want to put it in the Plymouth Independent, or see if they would like to write something about that? Or
Dr. Reed, I thought, was this the group where we were going to circle back with folks who have applied for the Board of Health positions in the past?
that too, yeah. Okay, so would we get that information from the select board? Or how would we get that information?
Yeah, we can request that from Jade Innerton, who is the administrative assistant for the select board. She could share the list of folks who have applied for, we can even go back, for the last 2 times or 3 times if we wanted to, people who have applied for Board of Health position that were not selected. And if, Dr. Reed and Meg or whoever wants to get together and draft a hello, welcome to public health letter. And are you interested in perhaps joining the Citizens Advisory Group? We here in the department would be more than happy to send those out.
Okay, and so I would get that list from Jade. What was the last name?
Anderton.
With an A or an E?
A.
Anderton. Okay, great. I will take care of that. All right, next tobacco regulation update. Amy.
So I think everybody has the version that was I made the edited edits from the last time. It was let me Margaret, do you have it or do you want me to grab it off of my computer?
I don't have it up.
All right, I'll
I'd have
grab
to
it.
dig. I'm sorry.
Yeah, no, I'm the same. I was like, oh, wouldn't it have been smart if I had this ready to go when I was just sitting here. All right, let me see. Yeah, I think that the changes that were made were, it's here it is. Back to Zoom. Do I have a share? Oh, here it is, share screen. All right, so this is the one, the most recent one that we have. The changes, this does have the 6 milligram nicotine restriction. And at the bottom, the changes that were asked to be made were around the violations for all first violations. So it says, so this was the big one where if you sell to somebody under the age of 21, your permit shall be suspended for 7 consecutive days. For all other first violations, the tobacco product sales permit may be suspended for up to 7 consecutive days. And then for the second violation, it was shall $1,000 for local policy violation shall be issued, and the tobacco sales permit shall be suspended for up to 14 days. Wasn't I supposed to put may on that? Was I going to do may be
Yes.
suspended?
Yes, it was.
Good thing I checked. All right, so it will be the tobacco permits may be suspended for up. Sorry, of course my dogs start barking now. And then the C is the may shall be suspended, may be suspended for up to 30 days. Sorry, I'm going to go mute because this dog is.
There's a shall in the in B.
I'm sorry. It shall be issued. So the fine of 1,000 shall be issued,
Shall
but
be
the
issued,
permit
okay.
may be suspended.
Yes, got it.
And then that, so is everybody good with those changes? I'm sorry I didn't have them before.
Is that okay?
Yeah.
Everybody? Okay. Okay.
All right. So, and then did you guys want to vote on it?
Well, can you go back up to the 3 milligram, 6 milligram?
The 6 milligram.
Yeah.
No retailer or person shall sell or distribute. Shall sell or distribute or cause to be sold or distributed oral nicotine pouches with a nicotine content greater than 6 milligrams per individual pouch.
Okay. So the caller that called earlier was concerned that we were eliminating 6 milligram pouches too, and we're not.
I think
Right?
he wanted us to not restrict it to 6 milligrams. To allow any
Oh, he wanted it even higher. Okay.
Yeah. And I mean I appreciate
Yeah.
I appreciate that these do help people kick tobacco, but I don't we're not what we saw in the last meeting was 6 milligrams for 2 to 3 cigarettes at a time. I'm just not sure. So I feel comfortable with the 6 milligrams, but I'm not sure how if anybody else is in opposition of that.
Yeah. And then Margaret, you sent us something today about 9 milligrams.
Yep, that was from Chad Perry, I believe. I feel like that was years ago, even though it was just this morning. Here's from Chad Perry of the Vape Way.
Okay.
Yeah, you all got that, right? Did you have a chance to look at it?
Yeah.
Yes.
Okay.
And he was Margaret, he was the one that last time had said that the FDA, when we were talking about FDA nicotine restrictions, he said that he was like, there's something that says if it existed beforehand, then was he the one? Do you guys remember they said that somebody called last time and said if this existed before the FDA came up with marketing granted orders, then that was allowed. Was it?
It
Oh,
may
Dan just
may
raised his
have been
hand.
Dan Griffin who
Yep,
works with
yep.
Chad, and Dan does
Okay.
have his hand raised.
Yeah, I can say I know when the next day I was at work and it did say that there was that the literature we have says that none of this existed before marketed granted orders came out.
Okay.
Right.
So
Okay.
that answered that because I definitely was caught off guard when he said that last time. And then
Yeah.
I saw the next day that it just didn't exist beforehand.
Okay. Okay. So I was not going to vote today on this, but I would like to vote on it next time. Can we have one more go through it, make sure that it says everything we want, with the shells and the wills and all of that.
I mean, I don't, did we say that we were, I thought we were going to vote on it this
I
time,
thought
but
we were voting on it because this has been going on a long time.
It's
yeah,
Oh,
not,
okay.
it's not on the agenda though. That's the only
It's not
problem,
on the
I think.
agenda. Yeah. We didn't put it on the agenda to vote.
okay.
Dr.
Well,
Potvin has his hand raised as well.
yeah, Barry.
Yeah, I was just wondering, do we need to include anything about the state ban on flavored tobacco and nicotine products?
It says that we have to follow the state law and within these regulations.
Okay, because I keep seeing these lists coming out from the FDA and that one company that makes the ones that have been approved, a number of those that are approved have either wintergreen or some other flavoring. So in Massachusetts, you still could not sell those,
Yep.
if I understand it
Right.
correctly.
I think our regulations say it too. Yeah. No person sale of flavored tobacco products prohibited. It's within our local regulations, but it also says, I think we have language lower that says you have to follow state laws.
Okay.
Right here, incorporation of state laws and state regulations.
And I'm fine with that. If we can legally vote on this, then I'm okay with that too.
I mean,
Okay.
we can legally vote, but I feel like out of courtesy, if it doesn't say vote taken, then we should wait. Like there's nothing that's legally preventing us, but I don't know what's going to change
Okay.
between now and in 2 weeks.
Well, it isn't. I mean, it'd take 2 seconds in 2 weeks to do
Right.
it. Karen, but we should wait. Karen, you feel?
I think in the to be consistent, because that's the
Yeah.
way that we've always done it. I wouldn't want to make a change with something that's been so diligently worked on, so that I wouldn't want anyone to question, what we did when people have worked so hard. Amy especially has worked so
Okay.
hard on putting this together. So I would certainly recommend that it be the number one thing on the agenda for the 18th, and we
Okay.
do it right off the bat. We'll put on the agenda, vote anticipated or in vote to be taken, and then we vote on it, and then we're done.
Okay.
Karen, I have a quick question. Do you send these out to the tobacco permit holders? Like, do you send out the drafts and say, hey, everybody, we're talking about this at the board, or it's up to them to make sure they're paying attention?
Right. What we will
I
do
get
is we'll
that.
send them the changes.
Yeah.
But
Yep.
yeah, I mean that's why you post your agendas, right? That's
Yep.
why your agenda's posted. That's
Yep.
why they can certainly, they call, and believe me, we've received phone calls, we've received emails.
Well,
Everyone who is interested in this subject has had ample
mhm.
opportunity to speak on this subject. I don't think that we're doing anything quickly. We're not trying to hide anything. We have been totally transparent. So I think that first thing on the agenda for the 18th is a vote, and then that's it.
I agree with you. And we've had people showing up. So we know that,
Yep,
and it's a tight-knit community. They're letting each other
yep,
know. And I think
absolutely.
if, we can, when we do vote, we'll have to decide when we want to implement this. And since
Correct.
everybody knows, that this is turning into, we can consider that when
Mhm.
we get ready to do. And the only thing is the 6 milligrams.
Right.
Yeah.
So.
Okay. Very good. Thank you, Amy. And then Katie. Katie is starting to work on some kratom regulations. You want to tell us what you've got so far or what you're doing?
Can you hear me?
Yeah.
Okay. I don't have them on my screen, sorry to share. But I know we're getting a lot of calls about obviously only ban 7OH. Are we going to ban kratom? What are we going to do? So I think that we kind of have to discuss how we're going to do that together as a board. I can give you my input on it and what I drafted so far. After going around on foot I went to 4 different gas stations in Plymouth, actually 5. Read all the ingredients, spoke to the clerks. And I can tell you that not one of the clerks, and these weren't smoke shops, these were gas stations in Plymouth. They were carrying the product. There was only one that I went to that didn't carry it. Not one of them had pure leaf kratom. There was absolutely nothing pure that they were selling. It was all synthetic. And also, none of the salespeople even understood the product they were selling. So they had no idea that there were any sort of addictive quality. They had no idea that there was any sort of danger attached to it at all. From what I can gather and from talking to people, there are neon signs that say kratom in other cities starting to pop up. I think that people hear the word kratom and they're thinking that it's safe, but they're being lured in and it's not necessarily safe. So the FDA did publish in December 2025 warnings. They are still not condoning any sort of kratom use. They are still very, very skeptical. There is no safe dosage that we are aware of. There is no dietary or medicinal purpose for kratom at all. So the stance that I have on it for now, for our community, would be to ban both and just to not sell either. The 7OH, I hope and I think we all are in agreement that it's extremely dangerous. We know that we have to ban the 7OH. It's more of an acute danger. We need to get that off the street as soon as possible. I really want to kind of move forward with this quickly because the more I talk to just people in the community, just kind of word of mouth, no one's really heard of kratom, but they are aware of the 7OH as just being some sort of substance out there. I have talked to some workers in different facilities as well, nurses, especially more on the Cape. It is popping up more and more. And they are getting people checking in with kratom also, withdrawing and pretty sick. So I think we need to move on it kind of quickly. I think I sent you the regulations, but Amy had drafted something also prior, so we can certainly merge them both together if we both found enough data that we want to include. But I did have stuff in there from December 2025 FDA and also the DEA as far as letting the public know what both are, the difference between plain kratom and the 7OH pills that are being sold, the dangers associated with both, and what I propose we do, which is to ban them both, to be honest. I don't see our community suffering a loss from not having access to them, just from what I've done in research. If someone else does, and that's great, I'm very open to talking about that. I think that this is becoming more and more of a problem as time goes on.
So the outline, the reg that I sent you
Mm-hmm.
was actually the one from our epidemiologist, Devin. And she sort of gave that as sort of a template.
Yes.
And then Amy has another one that's similar. And I just want to know from Karen or Margaret, is there a specific kind of a template that we have to follow with these regulations? Like the tobacco regulation had, certain things in it. Does it have to be a certain way, or is it just we can use any template?
No, there's no set template that you have to follow.
Okay.
Nope.
Okay.
I,
All right. So
I can tell you the one that I used was from it was the MAHB one. They have one that does
mhm.
kratom synthetic cannabinoids and and then I looked at a lot of other communities where what they were using, and
Yeah,
they're all very similar. So I
yeah.
think it comes down to whether it's all of kratom. I was in a meeting today where we talked about kratom versus 7-OH and kratom products, and there was a lot of there was a lot of discussion about the use of kratom itself and whether or not it's a cultural use, and are we being culturally insensitive if we ban everything. But the thing that I struggle with is the way it's all marketed here, and it's not necessarily about whether or not it's acceptable. It's how it feels that it is marketed within Massachusetts and online. And so, I mean, I agree with Katie. I feel like at this point, there and it's so hard because we keep talking about it over and over and over in local health is the kratom versus the 7-OH, but the train's moving fast. And do we act to get the 7-OH off the books and then revisit maybe when things change, or and that's something that the board needs to decide. I do lean with Katie because of the way kratom itself is marketed around here, and we're not familiar with it, and we don't it would be a lot to ask vendors to just cut it out completely, or have to go through it would be a lot to ask the vendors to go through it and determine what's raw leaf and what's not because of the way it goes.
Mhm. Well, what I'd like to do is maybe have us distribute again so everybody can read it. Amy's proposal and the one that you have, Kate,
Sure.
and start to read those things. Distribute them out to the board and start to read those things, and then we can get very serious about doing this next times. Okay.
Yeah.
I think we also need to, or should try, and I haven't had a chance to yet, to look at what the proposals are at the House and Senate level, just to see where they're headed or what their thinking is. I know this may take a long time for them to do, but at least kind of know what they're looking to propose so that we're not too far off. Still doing what we want to do. Okay. Does that sound good,
Yeah,
everybody?
that's
In
perfect.
agreement? Okay, very good. I did want to mention, Kate, while you're talking about Kratom, they have that webinar that's going to be coming up, and it's called Bright View: Emerging Drug Trends, Kratom, Tenap Teneptine, and other gray market area substances. This is going to be a webinar on February 25th from 12 to 1. So I think it might be useful. I signed up for it. It might be useful to listen to that as well. If you go out to Bright View, that's the name of the organization that's putting it together, and you can probably then sign up for it there. Okay. All right. And let's do the director's report.
Okay, I just have a few things tonight. One we've already talked about, which was the Shar Chip interview and the focus groups and the public information. Um, Second thing I wanted to talk about was we do have our Board of Health opening, and it is going to go before the Select Board, we believe, on February 24th. So that's what's happening there. And I believe people that we know have already applied. So that's a good thing. And just always, I recommend that whoever does apply be in person. They don't look fondly on people who are there via I shouldn't say that. Remote is okay. Make sure you do something. Don't not be there. So remote's fine, in person's fine. Just be present in some capacity. Um, and the last thing I wanted to talk about was Margaret Coe is officially our Assistant Director of Public Health, which I am thrilled about and well deserved. And I'm very excited to continue working with Margaret in capacity to help our residents and visitors here in public health. And well, just to start right off the bat, I will be on vacation starting Friday. I will not be back until February 17th. So, Margaret will be your go-to until that time because I will be out of the country and will not be able to answer you even if I wanted to. Feel free to keep emailing me so I can check those when I get back. But of course, Margaret will be your contact while I'm gone. So that's all I had tonight. Oh, and I did check very briefly, Dr. Rita, and I'm very frightened about those vapes. So we definitely need to put that on an agenda. The smart vapes.
Those smart vapes,
Very,
yeah.
very frightening.
Yeah, it is really
Yeah.
frightening. I'd never heard of it.
Yeah, I haven't either. And I just quickly looked at it while you
Yeah,
mentioned it, and it's shocking.
yeah, it is.
All right, thank
Yes. And then under new slash old business, I just wanted to remind all of us about the MAHB certificate program that is coming to our town March 21st. And that will be at the 1620 Hotel.
And if
So,
anyone's interested in going to that, there is funding available from the Public Health Excellence Grant. So if you want to just let myself or Margaret know that you're interested, we can probably make that happen.
very
And
good.
also Meg does have her hand raised.
Thank you.
Oh,
Just
hi, Meg.
hi. Congrats, Margaret.
Thank
Just
you.
real quick, I just wanted to bring up about our student representatives from Plymouth North and South. Can we touch base with them? I don't know, like, is there a regular connection with them? I don't know if they are aware of our meetings anymore. It seems like they've dropped off a little bit.
I know Dana, when she sends out the agenda, does include them. I did. Karen, do you know who the contact at the school was for that?
It's Patricia Fry for
Okay.
South, and I don't remember off the top of my head who it is for North.
All right, Karen, Dana will know. I can cover that with Dana tomorrow.
Yeah,
Yeah,
or
we'll
maybe
follow up on that, Meg.
maybe like they're not interested anymore and we could engage with other students.
Yes. Yep.
Yeah,
I think that's important.
and also I think the next meeting's during February school vacation, I think. So they probably wouldn't be there anyway, but we can certainly touch base to make sure they are still interested in moving forward. That's probably a good thing to do, Meg.
Thanks.
Yeah, like all this stuff about Kratom and
Mhm.
the smart vaping and stuff like that. I mean,
Yeah.
these are good topics for them to be involved in.
Right. That's
Yeah,
the group, right? That's the demographic.
yeah. Okay, very good. Anybody have anything else? Our next Board of Health meeting will be.
Dr. Potvin has, sorry, I'm sorry.
Oh,
Dr.
okay.
Potvin has his hand raised.
I can't, the way this is on my screen, I can't see the top.
That's what you got me for. I see
I don't
everything.
see any hands. Yeah.
Yeah, just a couple of quick things to cover under new world business. I believe usually the person who does the appointments for the student representatives is the principal at each of the schools. So I don't off the top of my head know the name of the principal at Plymouth North, but the student who is coming from Plymouth North was attending our meetings last year. And she continued at least at the beginning of this year, so I have no idea what happened. Another thing that the students might be interested in that we ought to start thinking about is that since we're always talking about addiction and trying to keep the students from getting addicted, there's a developing problem with sports betting and gambling, even among the high school students. And I'm not sure what we can do about that. But
There's a
it's
program I've talked about several times. There's a program that PYDC is putting on at the schools. about gambling.
We certainly ought to, get involved with that to the extent that it's a public health risk for our students.
Mhm.
The other thing is the good news. Governor Healy's proposed budget for fiscal year 27. I was able to locate the public health part of it. And apparently, although it has to still be approved by the Senate and by the House, and go through all kinds of committee hearings, she apparently put aside $15 million for grants to local boards of health for the Public Health Excellence Grant. May not stay that way, could go up, could go down, could disappear, and there's no way to know that. So obviously, and Meg is involved in this with me too. There is no concern for the funding for fiscal year 27 for the Public Health Excellence Grant.
Good. Okay. Any other comments? So our next Board of Health meeting is on 2/18 in person downtown, and that will be at 5 p.m. And if there's nothing else, we're going to end early if someone would like to make a motion.
I'll
Can I
make the
say
motion.
one more thing? Sorry. Dr. Reed, did we need to adjust a time so that you could make one of your meetings? Was there a conflict?
Oh, thank you for reminding me of that. So the school nurse wellness meetings, they are on the same day. Are we the second and fourth? No, we're the first and third.
Yes.
Mhm.
They're on the third Wednesdays of the month, and so I can get there, but only for half of the meeting. And I really would like to hear the whole meeting because I learned so much about what's going on at the high schools. So I was wondering if that meeting we could switch to 5:30 instead of 5, so I can get there from the school. So that would be the next. I think it was the next meeting. That was why I brought it up.
Just a question, Dr. Reed.
Yeah.
I believe they don't do that meeting monthly.
No, I know that.
I believe it's like 4 times per school year or
Right.
something like that. So we don't have to make the change for, all the meetings.
Right. The next one is March 18th.
Okay.
But
March.
March 18th
Okay, so we'll do 5 o'clock this one, but 5:30 in March.
in March.
Okay.
Will that be okay? I know it's confusing because it's like every other month. And I think after March, I'll only have one other one. And then they're done for the summer.
Yeah, it will make sure that the agenda is accurate and posted accordingly, and make sure everyone who is invited knows the different start time. That's not an issue for our division, that's for sure.
Oh, good. Yeah.
And the room's good, Karen?
I'm sorry?
The problem is, are we sure that we have the room available from 5:30 to 7:30?
Well, most likely we will not. We'll have it from 5:30 to 7.
Perfect.
And that will be an in-person meeting because it'll be the third meeting.
Right.
We'll just make people talk fast.
Yeah.
We'll scale it down.
And again, I think like Dr. Reed said, it's only a couple. I think it's important for Dr. Reed to be there. That's very valuable information that's given at that meeting. So I think it's a good balance even if we lose a half an hour for 2 more meetings, to have that information through you, Dr. Reed, would be important.
Yeah. Okay. All right. Thank you, Meg.
I know, Meg, good catch. We all talked about it and then never did it.
Reminding me. Okay, so now would someone like to make a motion to adjourn?
I will make a motion to adjourn.
Okay, a second.
I'll second.
Okay, and all those in favor? Barry?
Yes.
And Meg?
Yes.
And Amy?
Yes.
And Katie?
Yep.
And myself, yes.